Welcome to everybody who is joining us. It's great to have you here. We have a few more people to filter through from our waiting room into the main webinar space. So if you could just bear with us for a few minutes while, not a few minutes, a few moments while they come on through, that would be great. Thank you. So welcome to everybody who has joined. As I can see, the participant numbers are still ticking up, but I will make a start on introducing the day while people filter through. So this is the first of two VAM webinars this month, actually. So this is our December 3rd webinar, and we're delighted to be welcoming Karen Johns, who is the CEO and lived experience lead of Voices, a Bath-based Buying for Domestic Abuse charity, and also Claire Powell, who is a qualitative applied health researcher who is joining us from UCL. They're going to be speaking about domestic abuse and mental health of parents and children, talking through practitioner perspectives on supporting families and service coordination. If you are new to the VAM webinar series, then a particular warm welcome to you today. We run these events mostly monthly, although as I mentioned, we have two going on this month. And we're really aiming through them to bring to our members the latest research and analysis and service updates with an emphasis on the real world implications of the findings. It's really important to us that we have the opportunity to ask questions of our speakers. So we ask our speakers to talk for around 20 minutes, and then we have around 20 minutes of Q&A. You will have noticed that your mics are off and your videos are off. This is because we use a webinar format for these events. So I won't be able to call on you directly to ask your questions, but if you could please use the Q&A box, you should be able to find it on the bottom bar of the Zoom screen. I'll be monitoring that throughout the session today, and I'll be able to put your questions to Karen and to Claire. If you would like to use the chat box, you can use that, please, for introductions and to share resources. We know that there's a wealth of expertise and experience among the members on this call, so please do use that freely as well. I won't be monitoring the chat for questions, so if you do have a question that you want to ask Karen and Claire, please make sure that goes into the Q&A box. Just to reassure you that the webinar is being recorded, and you will have access to the slides after the event. So we will email you with a link to the recording and a copy of the slides. So you don't need to be frantically taking notes as you are listening to the presentation today. I think that is all I need to say for now, except thank you so much to Karen and to Claire for being with us today. We're delighted to have you, and I will hand over to you both to start your presentation. Thank you.
Thank you, Sian, and it's really good to be here. So we're here on behalf of a really big team of researchers, you can see, from City, Sussex and Bristol. And this research was done as part of the NIHR Policy Research Unit for Children and Families. And I'm going to hand over to Karen for a little brief introduction about Voices.
Thank you for having me. So we are a small domestic abuse charity, and we have been working with Claire and her team for a few years now with various PPI involvement work from a domestic abuse point of view. And we have our own lived experience group from our people who have gone through our services come out the other side and feel they want to put something back into change policies, procedures, so other people don't have to go through the same problems that they had encountered on their journey, as there are many systemic flaws that needs to be reevaluated and changed. So we've been working with Claire and her team for a while now, especially on this project as well. So happy to be here.
Thanks, Karen. So just as a bit of background work, the team that we work with are researchers and clinical academics as well, with lots of expertise in kind of health practice and domestic abuse. And from the literature and also their experience, we really know that health and social care professionals really vary in how confident they feel in responding to domestic abuse and the mental health impacts of domestic abuse, and how confident they feel in what they do. And this is even though we know that a lot of people accessing health services will have experienced domestic abuse. And we also know that kind of generally coordination between health and social care services can be really challenging, but also particularly when there is domestic abuse. So with that kind of, clinical policy context, we had two main research questions. So it was, how do services recognise and address child mental health, parental care and mental health, and interparental domestic abuse in families? And also, how do services coordinate for families experiencing both mental health difficulties and domestic abuse? So we took a qualitative approach. So this was a multi-interview study. And what we wanted to do is to think about how geography plays a role in service access. So we picked three very different areas of England. So a very rural area in the north, an area in the kind of West Midlands that was a city with rural outskirts, and an inner city London borough. This was to see both how the geography affects service coordination, but also how the people living in these areas might have different experiences of services. We decided to focus specifically on this kind of triad of services, so primary care, child mental health, and specialist domestic abuse services. And this was because it was sort of a first step and exploratory, and because we couldn't involve all health and social care professionals, and we thought this was a kind of an interesting place to start. And we did PPIE. So I think, Karen, do you want to talk a little bit about some of the things that Voices did for them?
One of the most important things as an organization is, of course, making sure that people are in a safe space to deliver this type of work. And because we have a lived experience group that has been going, I think it's about 10 years now, we've obviously come through a process where we talk to our team of lived experienced people, and we find out what is key for them. And it's vital that they are not re-traumatized through this process. So we put something in place where we know that they come together as a group. If they need support, we've got aftercare in place. And they're also acutely aware of the fact that they're coming in as experts by experience. So that added value comes along with whatever projects we're doing or undertaking with various researchers. And I'm talking about this now specifically because there are other organizations that would sign people up and say, we've got lived experience, you can tap into this. And there isn't any aftercare or support in place afterwards. So we're very mindful of this, that it needs to be a safe process for everyone who's going through whatever work that they're engaged with. And we take pride in that as a charity, and it's what we do. Lived experience is definitely key in how we operate. And this is how we treat the PPI engagement work. Back to you,
Thanks,
Claire.
Karen. And while this study wasn't kind of co-produced, it definitely came from Department of Health Priorities and the sort of clinical academics. What we were able to do was integrate Voices' suggestions for questions that we should ask professionals. So we added extra questions about specific training that we hadn't thought about. And then the group at Voices also came in on the analysis and really helped us interpret our themes and add extra kind of nuance and detail. So it was a really, it's always a very rich partnership, and it really expands our thinking as we go through. So this is who took part, and our aim was for roughly 5 of each type of professional in each of our 3 areas. So it would have been 15 of each. So as you can see, we didn't quite make that for all of our groups. We had a real challenge recruiting GPs, perhaps not surprising given the pressures they're under. So we reduced our targets and aimed for one GP in each area and one other practitioner based in a GP service. So we did get a spread across all 3 areas. We had a really great response from domestic abuse services in all our 3 areas, and we got a really good range of different domestic abuse services, so refuge, community services, perpetrator programmes. We've got some local authority commissioners and services and some buy-in for organisations as well. And in terms of child mental health, we also got a good range. We didn't quite meet our target, but we had a good range of different roles in all the tiers of mental health services across our 3 areas. So from kind of inpatient to that kind of first level in schools or primary care. So we nearly hit 40 across all 3 areas. So just some of our key findings as a teaser before we go into them in more detail. So I think the big one that really stood out and that everyone was talking about and came out in our systems mapping was this wall between CAMS, so child mental health services, and domestic abuse services. And professionals in both services really wanted to be able to communicate and work together and refer directly, but this didn't seem to be happening for lots of reasons. And actually, as we'll see in the next slide, they're sort of mediated by other services. We heard about 4 specific groups of children and families who are affected by access criteria to mental health services and not able to get the support that they need. And then we did a sort of deeper dive into CAMS practitioner perspective, so in the kind of statutory mental health services, to kind of understand some of the challenges that they face working with families who experience domestic abuse and what they find particularly difficult. And we're not going to present today, but they are in the papers if you're interested. We do have quite a big section on funding and commissioning that people highlighted as really important. It wasn't just about what frontline practitioners do. And we also heard about different beliefs between the different kinds of services and how that can also sometimes affect how they work together. So firstly, this wall between domestic abuse and CAMS services. So we did a systems map where we took out the kind of extracts from interviews that mentioned anything to do with relationships between services, and we put them into software that then helped us create this map. So as you can see, that kind of line between domestic abuse services and child mental health services is very much mediated by the voluntary sector and local authority services, with kind of positive and less positive relationships between them. Early help and children's centres and family hubs were really highlighted as helpful spaces for different services to coordinate and provide support. And we also heard about kind of, the adult focus services, the police, substance misuse and adult mental health, how they also really have an impact on how services work together. Primary care was a little bit on the outside, and that might partly be because we didn't talk to as many people, but also that, they are much less well integrated with mental health services and the local authority. Karen, I think you were going to add a little bit more around.
Well, one of the things that we highlighted, I think, when we came to this section was from a small domestic abuse charities point of view, as well as other charities around that we engage with. The highest wall that we encountered was that the services were so disjointed that it caused more harm than good, and there wasn't the connectivity. So people would have to go through the process and be passed from pillar to post. They would be repeating themselves and re-traumatizing themselves through the process again. And there were so many other barriers within for instance, even if we haven't spoken about the court system, but let's say it's under the policing side of things. There are so many barriers there as well, where the mothers may not have been allowed to speak about their situation. Their children couldn't go and get support because, of the court engagement. So there were quite a lot of other barriers. And from a domestic abuse services point of view, all we're doing is either we try to help or we try to signpost. So that was one of the issues that came up. It's so disjointed, and we need to work together to pull it all together nicely so that we can speed up the recovery journey for people in these situations. Thank you, Claire.
And so the next kind of topic was around these groups of parents and children who find it even more difficult to access mental health services in particular. And these were families that were talked about across all our areas and actually by all the professionals. So the first one was parents and children who are seen as too complex for that kind of first level of mental health support. So whether it's mental health support in schools, in primary care, or IAP, so the talking therapies. So then they're not appropriate for those kinds of low levels of CBT interventions. But at the same time, what professionals were telling us is that these families then were also not meeting the criteria for secondary mental health services. So whether that was specialist CAMHS or adult mental health services. So they were falling in this gap between kind of, the services that were available, and outside of the voluntary sector, that there wasn't anything in statutory mental health services that was easily accessed. We also heard about children who weren't meeting social care or risk thresholds. So practitioners said that often when children did meet these thresholds, it might be a bit easier for them to get into CAMHS, for example. But if they didn't, they still had a level of mental health need. Actually, there wasn't necessarily anywhere for them to go. We also heard about this small group of mothers with very high levels of mental health need and sometimes substance use, but who still had custody of their children. And because a lot of the support for domestic abuse and these needs is residential, often it's actually more for women who either don't have children or don't have custody of their children. So there's a gap there also for this group of mothers. And what we heard is because of these kind of challenges in access, when children are waiting a long time for services, things get worse, and then actually they no longer meet the criteria for the service they're waiting for because they're now in crisis or things have kind of changed substantially. When women are unable to access the support that they need at the time that they need it, this might mean that they return to abusive partners. And we heard a lot about the worries that practitioners have when families are bounced around different services, or actually the wait is so long that they don't want to engage. And some professionals were actually saying they didn't even want to refer if they felt that the referral might be unsuccessful because they didn't want to build expectations for families. And we heard a lot about how the voluntary sector and primary care are trying to fill this gap of the kind of thresholds, the waiting lists, and trying to do lots of extra things to kind of make things a little bit more smooth. Karen, I think you were going to add something here.
So again, if I'm going to, I think we'll look at this in the following slide as well. It is being mindful of the parents going through the system and you're co-parenting with perpetrators, which then escalate. It just escalates. And because of that, you find that the service providers or the professionals, they're aware of this and they almost concerned because they haven't had the training to help support people through this. So it adds to people being referred on properly to the right services for good outcomes at a later stage.
And then the final group is children who are still living with or in contact with abusive parents. And this was a big group of children that actually all the professionals really talked about. And often, if you're in this situation, children are excluded from mental health services or voluntary sector counselling because their living situation isn't considered to be safe enough to engage with mental health services or therapy. But for children actually for whom this never changes, this means that they can never access mental health support, or what they can access is very limited. And this was one of the big kind of areas of tension between the different groups of professionals, that there's no agreement on what kind of mental health support can be offered or accessed when a family's living in an unstable and unsafe situation. Did you want to add anything to this, Karen?
Yes, so I know I'm speaking a lot about the court side of things, but I think it's really important to register that a lot of people who go through this process and looking for support through the services end up in the courts if they have got children. It's inevitable in a lot of situations where they can't come to a compromise about child contact, and the abusive parent is fighting for full custody, or there's so much engagement again with the family courts. What I'd just like to add is there has been a change in the laws with regard to the presumption of parental involvement in the child's life, it was part of the Children's Act in 1989, and now that has been repealed in October 25. Because if you went through the process before in the courts, in the family courts, they would automatically try to come to a 50-50 agreement between the two parents to co-parent the children going forward, even with the abusive partner. And that opens the door again to the abuse just carrying on post-separation. And the children are then in shared living arrangements, which is very disruptive. And professionals again go, oh, we can't help and support here because there's no sure platform for them to work from because it's so unstable. So we're hoping now that as this has now been repealed, the presumption of parental involvement, that they would focus on, again, training to see how this fits in with the system change, a holistic system change, because it will take time for professionals to be able to support these children in a safe way going forward again. And I just needed to bring that in because it was a barrier to children seeking mental health support, as well as for the parent, the non-abusive parent, because that was used against them in a court of law, where they were seen to be an unfit parent because they were seeking support, mental health support. So there's been changes in the law to encourage people to do this now, to reach out for healing and recovery. Again, it's going to be a long process because it's a systemic change that needs to take place. Thank you, Claire. Back to you.
And this is just one quotation that I think kind of really illustrates that and what Karen was talking about as well. So one of the exclusion criteria for many of the young people's mental health service responses need stability. They need to be safe. But the problem is they've got high-level trauma symptoms, they're demonstrating harmful behaviours in school environments, but that's not seen as safe or stable enough to work with generic mental health services. So I'm going to move on to this spotlight on CAMHS and just kind of take you through a few key quotes, but they'll all be in the slides. So I won't go through all of them, but you will have them when they're sent round. And this was carried out by a master's student, Emma Jones, who led on the analysis. And there were kind of 4 key themes that she constructed. So one was about the kind of time needed and the complexity to understand family context when a CAMHS practitioner is working with a family who's experienced domestic abuse, and that actually they need to spend a bit more time to really understand the nuance of what's going on at home for a family. And then there were kind of 2 themes around working with parents. So one around supporting the non-abusing parent and actually the level of understanding and empathy that's needed. But sometimes they might have conflicting views, the therapist, and might act as a bit of a mediator between the parent and the young person. And then there was a lot on the interacting with abusing parents. And actually this was an area that was identified where practitioners did not feel skilled and lacked a lot of confidence, and there was a lot of worry about causing harm. And then the final theme was around this need for a team of superheroes, for a team of practitioners for lots of different backgrounds, but actually this is really challenging working across, adult and child services from different disciplines. So I'm going to just go straight to the 3rd theme because I think that's one of the ones that stood out, and obviously you can go back and see them. So I think, and this is one of the ones I think Karen also just has made reference to. So this is one of our practitioners, and she said, it's really complex for children because they might love this parent very much, but actually they have quite complex, difficult feelings, and how do you reconcile that? And she really felt that actually they hadn't had the training to really deal with this much more kind of complicated set of family relationships. And she then went on to say that she was very worried if she said something that made this man very angry, that he would then actually seriously hurt his family or kill them. And this kind of level of risk that she was having to deal with when working with the whole family network. Would you like to add anything, Karen?
No, I'm okay on this because
okay.
You've covered it. Thank you.
So that was just one of the kind of key things that really actually stood out from this part of the study. And then we had the team of superheroes, and actually what they felt was that, adult services perhaps don't have a role or see themselves as having a role in the family approach, whereas actually CAMHS really do see themselves as working with the whole family. And there were quite a few concerns that some of the adult services don't consider the mum's trauma and actually the kind of her experience of abuse and how that kind of affects the family as well. So just to kind of summarise, and then we've got plenty of time for questions. It was really clear that domestic abuse added a layer of complexity which child mental health professionals didn't feel equipped to address. And this was even though we know that the numbers of children who are accessing CAMHS, there's quite a high proportion who have experienced domestic abuse. The big knowledge and skills gaps were about post-separation abuse, so kind of really understanding all the context of how children will carry on having contact with abusive parents, and also how to work or interact with abusive parents as well. It became really clear as we went through this that the kind of standard family-focused approaches to working are not always appropriate in the context of domestic abuse, and they really need to be thought about, perhaps reformulated. And one of the things that Voices highlighted throughout, and that Karen has made reference to, is that, you know, there isn't always a choice about contact with an abusive parent. It may be court mandated, but there isn't always understanding about this and the kind of complexities about what may be going on. Do you want to add anything?
Can I just add something? I know if we look at this now, we say, oh, well, the presumption side of things have changed, so judges may not put pressure on families to interact with both parents if the one is an abusive parent. But you need to understand, we've been dealing with the courts, the family courts, for about 10 years now, and there are a lot of judges who would have the view that it's best practice for the child to have both, you know, involvement with both parents. And domestic abuse it's so difficult to prove in a court of law sometimes, especially if it's coercive control or something where you're not seeing the bruises, and there may not be evidence-based proof. And what happens then is they look at this, the child doesn't want to go to the other parent, the abusive parent, and the only other choice they have is to look at it and say, this could be parental alienation. And children who, so the symptoms, for want of word, for domestic abuse is very much the same as what you would see if a child is going through parental alienation. So it's the same thing, and it's very difficult for them to distinguish between the two. So they would put pressure then, or they could remove that child from the non-abusive person and give it to the perpetrator. So there's a lot of training that needs to still come from this, and it is about understanding domestic abuse. It is about understanding trauma-informed work in that space. But it's something to be mindful of going forward. Thank you, Claire.
Thanks, Karen. And then that was just kind of in the context of actually the wider system findings, that there was this gap and certain families find it more difficult. But actually, it's not just about what individual practitioners do. This all happens in a wider system, and it relies on funding and commissioning, attendance and strategic groups, and inter-service relationships as well. And what we thought was, you know, we need an improved response actually at all levels and specific pathways between CAMHS and domestic abuse. We found some great examples of best practice in all of our 3 sites, but these aren't being shared across the country, even though there's some really brilliant things happening. And we actually need a bit more research to really understand people's journeys through the systems and more about the mental health needs of parents as well. So thank you. That's everything from us. And we've got 2 papers if you're interested in finding out more. And there's the link there also to Voices website, which was newly launched last week.
That's lovely. Thank you so much, Karen and Claire. Deezer, behind the scenes, could I ask you to just put in the chat the links to those 2 papers, please, and also the link to the new Voices charity website, because that will mean that Claire can take the slides down, which makes the Q&A a little bit easier. Thank you so much. Look out for those slides appearing, links appearing in the chat. We've got time for questions, which is great. Thank you. Claire, you mentioned that there were examples of really promising best practice at all 3 of those sites. And I wondered if you could talk a little bit more about some of those examples so we can take the opportunity to learn from them right now.
Yeah, of course. So there were 3 and they were all quite different. So there was one specialist counselling services specifically for children who've experienced domestic abuse. And this is really very unusual. So that was their complete speciality. So that was a really great service. And they had really good relationships with mental health services and domestic abuse charities, so acted as one of those kind of brokers. We heard about some really great co-commissioning of a domestic abuse service and a child mental health charity that had been jointly commissioned to offer support to young people. But the really extra kind of good bit was that the child mental health charity had direct links with the local mental health services. So again, they acted as that bridge, and they already had sort of another service that was, I think, partly funded by the NHS. So, but that had entirely come from commissioning and funding. I think there'd been informal relationships originally, but it was solidified by great commissioning. And then the third one was a local authority service that was offering basically case advice to all health and social care practitioners in the area for any cases where they had where there was domestic abuse. And so it was a kind of expert consultation for professionals that they could go and get expert advice of, I'm working with a parent who's an abusive parent, what should I do? And that was also very unusual and very, very valuable, and kind of bridged some of those gaps.
So bridges, not walls, is the I suppose the thematic point. So the point you raised there at the end about the kind of the consultancy or the consultation service sounds really valuable, because you talked about the knowledge and skills gaps for these professionals. And when you were looking across these sites, what did kind of training on domestic abuse look like for CAMHS professionals at a kind of, if you're able to speak in generalities, what was that looking like?
That there isn't really any training, I think is the short answer. There were some people who had previously worked in the voluntary sector and had moved to CAMHS, and they brought with them knowledge and skills from having worked in the voluntary sector or having volunteered. But on the whole, there was more knowledge and awareness of mental health and training in the voluntary sector and the domestic abuse sector than there was of domestic abuse in CAMHS and kind of statutory mental health.
Which seems incredible when we know what we do know about experiencing domestic abuse as a child, or being a child in a household where there's domestic abuse, and the impact that has on child and adolescent and adult mental health. Okay, thank you. I have a question around, has it been published yet? Yes, it has. Links are now in the chat. And somebody who has conducted similar research with multi-systemic therapy and had very similar findings. So if you are the person who submitted that, if you would like to pop that in the chat so people can benefit from those findings too, that would be great. So the findings of those two studies are suggesting additional training for staff working with families where DV is a concern. Were there any themes around how practitioners can support with safety planning?
No, I don't think that was what we looked at specifically. I think it was more around, there was disagreement between the two sides about how safe a family needs to be before they receive mental health support. And there's quite a lot of diverging views within people we interviewed and then people who we've presented the findings to. So it was more actually about what kind of mental health support can you offer when people are not in a situation of safety, and what is appropriate and what isn't. So that was kind of the level that we were answering and sort of looking at as well. I don't know, Karen, if there's anything you would...
Well, I think it just comes down to collaboration again, and making sure that you ask for help. We have professionals coming to us and asking us for support in, with regards to domestic abuse, where they literally put their hands up and say, we don't know what to do with this case. And there's no way we're going to turn them away. We will help wherever we can. And especially in this climate at the moment, with all the funding going, lots of smaller charities are closing, and we are in a situation where we're going to need as many people, as many professionals as possible, trained up in domestic abuse, just being able to identify it and how to cope with people who are coming through their doors, because we are heading for a situation where as many people as possible need to be trained in domestic abuse related work across the board. And it's collaboration.
And people were asking for that. So the mental health service was saying, we'd really like training from domestic abuse agencies, or kind of more formal links,
And
and domestic abuse services saying, oh, it'd be great to have a supervisor from a mental health service that could oversee some of so that there was
yes,
definitely will on both sides.
that's right. And we've been doing work with, so we had again, another point of entry for the situation would be the health visitors, because they've got entry into people's houses. So we've been having a lot of engagement work with health visitors and other universities doing research work on this as best practice with regards to domestic abuse. It's about collaboration. It comes down to that. Thank you.
Just a question about the scope of the research. So it was, I believe it was all professionals interviews that that you've been drawing on here. There was a point that all of the quotes refer to male perpetrators, and a query therefore whether the scope of the interviews included fathers as victims, and whether it would have also included gay and bisexual couples where abuse was present.
So the participants were practitioners, and actually not all of the examples, but definitely the examples I've quoted from were definitely around straight relationships, where the abusive parent was the father. But I mean, no, it did apply more widely, but I think professionals who'd worked with families in different situations actually were underrepresented, and that's definitely something that needs more research. So we're definitely not saying that that's the only way that domestic abuse happens, but that's definitely what most of the practitioners were talking about in our study.
And excuse me, a further question. Many parents who've experienced domestic abuse find themselves constantly firefighting referrals and allegations, which can overshadow more subtle neurodevelopmental needs such as autism or masking. What guidance can services offer to help parents and schools identify when behaviours are trauma responses and when they may indicate underlying neurodiversity?
That's a really important question, and this came up a lot with some other work that I've done in domestic abuse shelters, where the staff were recognising the children were presenting in ways that would get them referrals to neurodevelopmental services, but they felt actually it was more of a trauma response. And this is probably one of the things actually where you need services to work side by side, and a sort of increased awareness of kind of the impact of trauma on mental health and the different ways that it can present. So I think, it's definitely one of those things where people need, if they find out a family's had an experience of domestic abuse, they possibly need to talk to experts around what else could be going on as well. Karen, did you want to jump in too?
No, you covered that. That's fine.
And you mentioned that family-focused approaches were often not appropriate here. I wonder if you could just spend a bit of time talking about what a better response and a better intervention would look like.
That's quite a big question, but I think it's about there being more nuance and complexity, and kind of really understanding the family dynamics and understanding the different ways families can be unsafe, the levels of risk. And I suppose again, I think Kara's made reference to this, is not necessarily assuming that both parents could or should be involved, and how that might work, and understanding how to interact safely with people who are using harmful behaviours. And at the moment, outside of kind of specialist perpetrator interventions, that knowledge and skills is very limited, and there's very few of those support services available. So it's actually very difficult. It's not something that's widely known about, and there's not very much training for either. Did you want to jump in, Karen? Or...
No, I think the training aspect that we find is a lot of people do not have the funding to support that element of the work, and it's just about going and asking. We've done training for smaller organizations as well, where you can negotiate something. It doesn't have to be exorbitant. Now knowledge is power, and we need to help each other along on this. And the more we get that out there, and the more people understand not just the trauma responses, they also need to understand perpetrator tactics, because if you're dealing with a perpetrator, how you deal with them would often cross over into how you dealing with the children or the mother or father, whoever's the non-abusive parent. So I think it has a lot to do with coming together, the collaboration I'm going back to again, and reaching out, reaching out.
Thank you. And a further question. I'm really surprised about support for practitioners around working with families where there are domestic abuse risks. I work in a large NHS trust and the local Safeguarding Children Partnership provides lots of support. It sounds like in other areas this doesn't happen. I wonder if this had been requested and what the LSCP, Local Safeguarding Children Partnership, responses to this had been. Do you have any knowledge of this?
Yeah, I mean, so I suppose bear in mind this was a small scale qualitative study, so I'm not generalising to the whole country. However, I do think even when training is available, it's not always taken up. And we do know from other colleagues' works that there are groups of professionals who don't necessarily think it's something they need to know about. So we spoke to a GP in this study who said that she finds that when domestic abuse training is offered to primary care practitioners, it's mainly the female doctors who go, and a lot of doctors don't think it's their business or something that they can deal with. And we also heard from practices where they had IRIS advocates. So these are domestic abuse advocates based in GP surgeries. We had one IRIS advocate take part in our study, and she felt that some of the GPs were interested and engaged and would refer to her. But actually there was a cohort of GPs within her practice, again, who didn't and felt it was outside of the scope of health. So I think you're right, training varies, but I don't think even if it's there, people necessarily take it up. And I think we were really surprised at some of the mental health practitioners who had trauma in their job title, who felt that this wasn't a relevant study for them to take part in. So even though they were some kind of trauma-informed mental health practitioner, they didn't see a study on domestic abuse as being relevant to them or apply to them in their practice, which I think is interesting. So I think there are gaps, and I think it's about raising awareness that it's very relevant for health practitioners as well. Karen, do you want to?
I think the only other thing that I would note is that there is an element of burnout as well among practitioners where they just cannot cope with anything extra coming their way. And you see this happening quite often. I think it's important if it's mandated, if the training is mandated, because in the long run, it will help them cope better, because they would get the right skills to not just identify what's before them, but how to cope with it for their own well-being, for their own sake. When they leave the practice, they're not worrying about the person. They know that they've identified it and they've managed to pass this on to the right people. And so it's beneficial for everyone in the long run. You can't go wrong with the training element to this.
Thank you both. I'm going to close questions there because we are nearly at time, but just to recap some of the key points that came up during your talk today. You spoke about how domestic abuse adds a layer of complexity which child mental health professionals don't always feel well equipped to address. You talked about the gap between domestic abuse services and statutory child adolescent mental health services, so them not always working together, having sometimes conflicting perspectives of each other in their work, and the need to address gaps in service coordination, and the importance of a multi-level response from funding and commissioning in helping to close that. Absolutely delighted to have had you both here speaking with us today. Thank you for such an important and clear presentation. Thank you very much everybody who joined us on the webinar today. We do have another webinar just next week. The link has just appeared there in the chat. You will also find it on our LinkedIn page. I hope to see you there. If not, do look out for our series that are starting again in the new year. You will receive the recording and a copy of the slides in the next couple of days. So please look out for those and go well. And with that, thanks. Bye.